Here's a scenario that happens about 15 times a shift. You get handed an ECG for a patient with syncope, but this one is harboring a critical can't-miss diagnosis: hypertrophic cardiomyopathy. The ECG shows LVH as well as narrow, deep, dagger-like Q waves in the inferior and lateral leads. The classic story is of a young patient who presents with syncope on exertion. While these patients can present with stable vital signs and normal mental status, hypertrophic cardiomyopathy predisposes patients to ventricular dysrhythmias and sudden cardiac death. In fact, cardiac arrest in a young patient should at least prompt the consideration for hypertrophic cardiomyopathy as the underlying cause. We're often taught that patients with hypertrophic cardiomyopathy should be treated with beta blockers. This slows the rate, increases LV filling, which relieves the outflow tract obstruction. But in the patient with cardiac arrest, we're not going to be reaching for beta blockers. What we can do to help control the heart rate is to reach for pressors that don't increase the risk of tachycardia. So I would be reaching for norepinephrine or phenylephrine instead of epinephrine. Another pro move is to use Dexmedetomidine for sedation, as it can have bradycardia as a side effect. The key point is, remember to scour your ECGs looking for hypertrophic cardiomyopathy, those deep dagger-like Q waves, before the patient develops a lethal ventricular dysrhythmia.